Today's in infectious diseases, we are discussing neurocystic sarcosis. In this, we are discussing on introduction, pathogenesis, classification, clinical presentations, investigations, diagnostic criteria, differential diagnosis, and treatment. As far as history is concerned, neurocystic sarcosis is an Asian disease. Hippocrates recognized human tapeworms. Aristotle compared their appearance to hailstones. Kuchenmeister in 1855 confirmed the larval stage. When Beneden demonstrated cysticerca in the pig muscles. Cysticercosis is a disease caused by the presence of Cysticercis cellulosae and Cysticercus racemose, the larval form of Taenia solium. Neurocysticercosis NCC is the most common parasitic disease of the nervous system. It is the leading cause of adult onset epilepsy. That is, in 29% of epilepsy in endemic region worldwide in the developing world. As far as epidemiology is concerned, 50 million people have cysticercosis worldwide. Underestimated since many cases are not diagnosed. Cystodes are cosmopolitan in distribution. Highly endemic in Latin America, Africa, India, China, and Southeast Asia. NCC, most common cause of adult onset seizures in developing countries. This is the diagram showing prevalence in different areas of world. Now, as far as etiology and pathogenesis is concerned, the adult tapeworm generally resides in the upper jejunum. The scolex attached by both sucking discs and two rows of hooklets. The adult worm usually lives for a few years. The mature tapeworm usually 3 mm in length. May have as many as 1000 proglottids, each of which produces up to 50,000 eggs. Proglottids are released and excreted into the feces, and the eggs in these proglottids are infective for both human and animals. After ingestion of eggs by the pig intermediate host, the larvae are activated, escapes the egg, penetrate the intestinal wall, and carried to many tissues. They are most frequently identified in striated muscles of the neck, tongue, and trunk. Within 60 to 90 days, the encysted larval stage develops. These cysticerci can survive for months to years by ingesting undercooked pork containing cysticerci. Humans acquired infections that lead to intestinal tapeworms. Infections that cause human cysticercosis follow the ingestion of Taenia solium eggs. The eggs are sticky and may found under the fingernails of tapeworm carriers. Transmission is usually associated with close contact with tapeworm carrier. Auto-infections may occur if an individual with an egg producing tapeworm ingests eggs derived from his or her own feces. Rare causes includes contact with infected persons, fingernails, soil, feces, and vegetables. Now, about the life cycle of Tinea solium. This diagram is showing the life cycle of the Tinea solium, cysticercosis, neurocysticercosis, how it occurs, the infections from man to pig, pig to man, the diagram is showing. This is also showing the same. Now, types of cysts. Cysticercus cellulose, less virulent form, smaller than less than 2 centimeter, round, thin walled, lodges in the parenchyma or subarachnoid space, provoke only a minor inflammation, often remain silent. Cysticercus racemosi, large lobulated cysts with predilection for basal cistern, causes cysticercotic erythroiditis and present is meningitis. Causes obstruction of fourth ventricle and resultant raised ICP and hydrocephalus. Intracranial pressure is raised and hydrocephalus develops. Can cause occlusion of vessels and vasculitis resulting in stroke. Can cause stroke due to occlusion of the vessels. Causes intense inflammatory reaction and seizures. Now, mode of infection. Humans are both intermediate and definitive hosts. Cysticercosis develops when human becomes intermediate host by ingesting the embryonated eggs of the tapeworm, which release oncospheres that penetrates the intestinal wall, enter the bloodstream and disseminate into the tissue. Mode of infection. Heteroinoculation. Eggs may come from the environment. Internal autoinoculation, regurgitated from proglottids into the stomach. External autoinoculation from the finger of an infected person. Target tissues. Predilection for meningitis to eye, CNS and striated muscles, probably due to high glycogen and glucose content of these tissues. CNS and eye involvement is termed as neurocysticercosis. Now, as far as classification is concerned, classification is anatomical classification, Sotelo et al. Classification, Carpio et al. Classification, and Korobisky classification. Now, in anatomical classification, parenchymal NCC, that is neurocysticercosis, interventricular neurocysticercosis, meningeal NCC, spinal and ocular NCC. Sotelo et al. Classification, it includes that active form of NCC represents both viable, live and degenerating parenchymal cyst, arachnoiditis, hydrocephalus secondary to meningeal inflammation, parenchymal cyst, brain infarction secondary to vasculitis, mass effect due to large cyst or cyst clumps, intraventricular cysts, spinal cysts. These are the active form of NCC. Inactive form of NCC, parenchymal calcifications, hydrocephalus secondary to meningeal fibrosis. In Carpio et al. Classification, these are divided into three, that is active form, transitional form and inactive form. Inactive form refers to live viable parenchymal or extra parenchymal cysts rarely produce symptoms apart from the rare instance of mass effect. In transitional form, symptomatic seizures with these forms, degenerating subarachnoid cysts produce meningitis, arachnoiditis, and hydrocephalus. Ventricular cysts lead to acute hydrocephalus. Inactive form, single or multiple parenchymal calcification. Calcification is inactive form or hydrocephalus secondary to meningeal fibrosis. Now this is Korobisky classification in group 1, 2, 3. Group 1 clinical features: space occupying lesion, intracranial tumor like behavior producing focal neurological manifestations and ultimately raised ICT. Surgical implications: exorcis often indicated. In group 2, diffuse cerebral syndrome due to numerous cysticerci leading to cerebral edema, intracranial hypertension, organic brain syndrome. In surgical implications, exorcis rarely useful but may be undertaken in life-threatening conditions. In group 3, basal meningeal or ventricular cysticerci giving rise to hydrocephalus and intracranial hypertension. But focal signs and mental rarely focal signs and mental disturbances. CSF diversion procedure is the surgical implication. Now, stages of involution. While in the nervous system, the tinea solium parasite goes through different stages, which includes the following: vesicular stage, colloidal stage, granular stage, and calcific stage. In vascular stage, cyst with a translucent vascular wall, transparent fluid, and a variable, viable, invaginated scolex. Mild host inflammatory reaction in vascular stage. In colloidal stage, thick vascular wall, fluid turbid, scolex degenerates. Varying degree of acute and chronic inflammations. Radiographically, cystic lesion with edema and enhancement and seizures are common. In granular stage, thick vascular wall, degenerated scolex, gliosis, mild inflammatory host response, and fourth one is calcific stage. In clinical presentations, the diverse clinical presentations of NCC is determined by location of cysts, size of cysts, cyst loads, number of cysts, and host's immune response. Clinical presentation: asymptomatic to life-threatening, can affect parenchyma, subarachnoid space, or intraventricular system, eye, and spine, dependent on the location, number, and stage of the cyst at presentation. Leading cause of adult onset epilepsy in endemic areas, that is Latin America, Asia, and Africa. Seizures. Commonly generalized tonic-clonic or simple partial, more frequent in patients with parenchymal disease, can occur in patients with cysts in the cortical sulci. Usually occurs when dying cyst incites an inflammatory reaction. Has been reported in cystic stage. 50 to 70% of patients experiences recurrent seizures. Also occur secondary to vasculitis and infarction in setting of subarachnoid disease. Positive correlation between endemic population with increased proportion of calcification and seizure activity. Calcified granulomas have increased risk of ongoing seizures. Perilesional edema related to calcification occurs episodically associated with seizures, accompanied by enhancement around the calcific focus. Focal neurologic sign develops upon number, size and location of the parasite in individual parenchymal disease. Cystic encephalitis. Intracranial hypertension in patients with parenchymal NCC seen in children and young women. Acute inflammatory response to massive cystic circle infection resulting in the brain edema. Presents with clouding of consciousness, seizures, decreased visual acuity, headache, vomiting and papilloedema, that is subacute or acute in onset. Treated with mannitol and corticosteroids may require decompressive temporal craniotomy. No use of antiparasitic agents. Other causes of intracranial hypertension: large cyst displacing midline structure or obstruct the flow of CSF at aqueduct. Subarachnoid NCC seen in sylvian fissure or basilar cistern. Normal evolution not occur in the intraventricular or subarachnoid form. Racemose type aberrant proliferating cystode larvae, local mass effect, arachnoiditis resulting in communicating hydrocephalus secondary to chronic inflammation or fibrosis of arachnoid villi. Cysticercotic arachnoiditis can lead entrapment of cranial nerves in the inflammatory exudates. Extraocular muscle paralysis, diplopia and papillary abnormalities. Decreased visual acuity, visual field defects, acute aseptic meningitis, signs of meningeal irritation are rare. Cerebrovascular complications, cerebral infarction, transient ischemic attacks, that is TIA, brain hemorrhages, ICH, mechanism, that is cerebral arteritis, particularly with subarachnoid cysticercosis. Medial sized vessel involvements are common. Ventricular NCC vary according to size of parasites, their location inside ventricular system and the coexistence of granular ependymitis. Lateral ventricles syndrome of increased intracranial pressure may be associated with focal neurological signs due to compression. Third ventricle cysticercia progressively worsens headache and vomiting due to developing obstruction. May presents with sudden loss of consciousness from acute hydrocephalus. Paroxysmal headache and vomiting secondary to intermittent obstruction at the level of cerebral aqueduct. Fourth ventricle, subacute hydrocephalus that may associated with signs of brainstem dysfunction secondary to compression of fourth ventricle. Brown's syndrome, fourth ventricle cyst characterized by episodic headache, papilloedema, neck stiffness, sudden positional vertigo induced by rotatory movement of the head, nausea and vomiting, drops, attacks and loss of consciousness. Rapid recovery and long asymptomatic stage period. Cysts In the third and fourth ventricle, cause of sudden death due to acute obstructive hydrocephalus. If cyst is in third and fourth ventricle, due to acute obstructive hydrocephalus, sudden death may occur. Granular ependymitis, degenerating cysts in the ventricle granular ependymitis, degenerating cysts in the ventricles can result in inflammatory reaction throughout the ventricular system. Cysts fixed to the ventricular wall with strong adhesions and fibrosis leading to hydrocephalus tend to have more chronic course. Spinal cord involvement, 1 to 5% of all cases. Extramedullary are more common. Intramedullary cysts are most common in thoracic spines. Extramedullary cyst or leptomeningeal NCC, extension of subarachnoid disease migrated from basilar cistern. Single or may form clumps. Combination of radicular pain and motor deficits of subacute onset and progressive course. Intraocular cysticercia, most commonly in subretinal space, progressive disease in visual acuity. Vitreous cysts, worsening vision with perception of something moving within the eye. Anterior chamber cyst may induce a severe iridocyclitis. Retroocular intraorbital cyst, decreased visual acuity due to pressure on the optic nerve. Stool routine and microscopy. Now the investigation part, stool routine and microscopy, eggs and proglottids in stool, blood examination, peripheral eosinophilia only if cyst is leaking, raised IgE levels. Third one is ELISINE CSF. ELISINE CSF, that antibody detection in CSF is more reliable than on serum. It is the most widely used test of CSF. Sensitivity of 87%, specificity is 95%. EITB, that is enzyme linked immunoelectrotransfer blot assay, test of choice for detecting anti-cysticercal antibodies. Uses affinity purified glycoprotein antigen. The test is 95% sensitive and 100% specific, superior to both ELISA and PCR. Fifth, CSF. It is insensitive and non-specific in the diagnosis of cysticercosis. Normal in 45%, most common finding is mononuclear pleocytosis and raised protein. Other are eosinophilia, high immunoglobulin, IgG index. EEG, abnormal in 56%, most common finding is sharp waves and spikes. Seventh is fundoscopy, parasite in subretinal space. Biopsy and histopathology, biopsy of a subcutaneous nodule or muscle lesion, demonstration of the organism is diagnostic of cysticercosis. CT with contrast, it is the preferred imaging study for detection of parenchymal calcification. 10th one is MRI. Now CT with contrast, the slide showing it is preferred imaging study for detection of parenchymal calcification, stages vascular, colloidal, granular calcified, cyst wall, scolex, cyst wall in vesicular, non-enhancing, well-defined membranous, scolex only, one viable scolex, eccentric, hyperdense, hole with dot appearance, suggestive of viable larva. In colloidal stage, ring enhancing with perilesional edema. In scolex, degeneration, the scolex fluid becomes more turbid. Earliest stage in the cyst, involution, larval degeneration. Granular stage, focal nodular enhancing necrotic lesions with perilesional edema. In scolex, degenerative scolex, eosinophilic structure, bladder and scolex are in various stages of disintegration. In calcified, small hyperdense nodule without perilesional edema. These are the features of CT with contrast. This slide is showing the CT scan. They see the neurocysticercosis. Now, as far as MRI is concerned, MRI modality of choice for intraventricular and cisternal subarachnoidal cyst, very small cyst, cystic degeneration and pericystic inflammatory reaction. Newer MRI techniques are MRC, that is magnetic resonance cinematography, flare, fluid attenuated inversion recovery. This is stage-wise vascular, colloidal, granular, cis fluid, T1 weighted image, iso-intense, T2 weighted image, iso-intense, perilesional region, no edema, no enhancement. Other comments, single P in the pod, hole with the dot, multiple Swiss cheese appearance in vascular stage. In colloidal stage, T1 weighted image, hyperintense, T2 weighted image, hyperintense. In perilesional region, surrounding edema is T1 weighted hypointense, T2 weighted hyperintense. Other comments on T2 weighted, the hypointense cyst wall stand out between the hyperintense cyst fluid and edema. Granular stage, same as above, as in colloidal stage. Calcified edema with high signals surrounding the low signal cyst. CT versus MR. MRI preferred since it is more sensitive in detecting small lesions, brainstem cisternal cysts and intraventricular lesions, perilesional edema and around calcific lesions. Scolex, degenerative changes in the parasite. CT scan preferred for cheap because it is cheaper, small areas of calcifications, cysticercal infestation of extraocular muscles. Now the slide is showing MRI showing cysticercus in the lateral ventricle with the resultant hydrocephalus. CT showing multiple intracranial calcifications, starry sky appearance. Now table, revised diagnostic criteria for neurocysticercosis. Absolute criteria, neuroimaging criteria, clinical exposure criteria. Absolute criteria, a histologic demonstration of the parasite from biopsy of brain or spinal cord lesion, visualization of subretinal cysticercus, conclusive demonstration of scolex with the cystic lesion on neuroimaging studies, neuroimaging criteria, major neuroimaging criteria: cystic lesion without a discernible scolex, typical small enhancing lesions, multilobulated cystic lesion in the subarachnoid space, typical parenchymal brain calcifications. Confirmative neuroimaging criteria: resolution of cystic lesions spontaneously and after cysticidal drug therapy, migration of ventricular cyst documented on sequential neuroimaging studies. Now, third one is minor neuroimaging criteria: obstructive hydrocephalus or abnormal enhancement of basal leptomeninges. Clinical exposure criteria: major clinical exposure criteria, detection of specific anti-cysticercal antibodies, for example, by enzyme-linked immunoelectrotransfer or cysticercal antigen by well standardized immunodiagnostic tests, cysticercosis outside the central nervous system, evidence of household contacts with Taenia solium infection, minor clinical exposure criteria, clinical manifestations suggestive of neurocysticercosis, individuals coming from or living in areas where neurocysticercosis is endemic. Now, as far as differential diagnosis is concerned, classification of intracranial space occupying lesion: congenital, traumatic, inflammatory, and parasitic. Congenital, this is dermoid, epidermoid, teratoma. Traumatic, subdural and extradural hematoma. Inflammatory, abscesses, tuberculoma, syphilitic gumma, fungal granulomas. Parasitic, cysticercosis, hydatid cyst, amoebic abscess, cystoma japonicum, and neoplasm. Differential diagnosis etiologically: bacterial, fungal, parasitic, neoplastic, and inflammatory and demyelinating. Bacterial, bacterial, pyogenic abscesses, tuberculoma and tuberculous abscesses, Mycobacterium avium intracellular infection, syphilis, listeriosis. Now, fungal infection: nocardiosis, actinomycosis, rhabdomycosis, zygomycosis, histoplasmosis, aspergillosis, mucormycosis, and cryptococcosis. Parasitic: neurocysticercosis, toxoplasmosis, amoebic brain abscess, echinococcosis, cerebral spongiosis, Chagas disease. Neoplastic metastasis: primary brain tumors, primary CNS lymphoma. Now, inflammatory and demyelinating, that is multiple sclerosis, acute disseminated encephalomyelitis, sarcoidosis, Beckett's disease, Whipple's disease, systemic lupus erythematosus. Cysticercosis with tuberculoma versus tuberculoma. Cysticercus granuloma, tuberculoma. Cysticercus granuloma round in shape, tuberculoma is irregular in shape. It is cystic, it is solid, 20 mm or less with ring enhancement or visible scolex greater than 20 mm. In cysticercus, cerebral edema not enough to produce midline shift or focal neurological deficit. In tuberculoma, associated with severe perifocal edema and focal neurological deficits. In cysticercus, MRI, choline, creatinine ratio less than 1, MRI. In tuberculoma, choline creatinine ratio greater than 1. Treatment options: cysticidal therapy plus steroids, corticosteroid alone, supportive anticonvulsants, anti-edema, analgesics, surgery. Antiparasitic drugs, parameters, cost, CSF penetration, efficacy with anticonvulsants with steroids. Albendazole, praziquintal. Albendazole is cheaper, praziquintal is costlier. CSF penetration, albendazole is good, praziquintal is poor. Efficacy more than 75 to 90%, less than 60 to 70% in praziquintal. With anticonvulsant does not interfere. Praziquintal interact with steroid, does not interact. Praziquintal interact. Albendazole superior to praziquintal. Giant cysts, subarachnoid cysts, intraventricular cysts, and spinal. Doses: praziquintal suggested single parenchymal cyst 50 mg per kg per day, 3 divided doses, 15 days, 6 hours, 6 hourly. Multiple cyst 50 mg per kg per day for 15 days. Albendazole suggested single parenchymal cyst 15 mg per kg per day for 3 days. Multiple cyst 15 mg per kg per day for 1 week. Large subarachnoid cyst up to 30 mg per kg per day for long time. Steroids, antiparasite are generally given simultaneously with steroid to control the edema and intracranial hypertension. Dexamethasone 4.5 to 24 mg per day, prednisolone 1 mg per kg per day. Anticonvulsants recommended for patients who presents with seizure. First seizure due to inflamed cysticercal lesion should be considered acute symptomatic seizure and should be treated only for the duration of acute condition. However, treatment may be continued during the period when the inflammatory response is active, which might last for several months. Should be stopped after resolution of acute lesion. Seizures occurring after resolution of edema or calcification of the degenerative cyst should be considered unprovoked, and long-term AED administration is warranted. Should be considered in patients with multiple cysts who have no history of seizure activity. Duration remains undefined and depends neither on the type of seizure at presentation nor the other risk factor for recurrence, such as age at onset and number of seizures before diagnosis. Although the usual practice has been to use AED for 2-year seizure-free interval, shorter duration of AED have been proposed. It seems prudent to withdraw anticonvulsant after 1 year seizure-free interval in cases where the lesion has disappeared and the EEG has normalized. Longer durations are needed for those with persistent or calcified lesions. This is the chart is showing degenerative, transitional and active cyst. Initiate AEM, CT or MRI after 3 to 6 months. Cyst not resolved with or without seizure recurrence. Cyst resolved but seizure recurrence. Maintain AEM and CT or MRI at 3 to 6 months. Maintain AEM for 1 to 2 years after last seizure. Only calcification, initiate AEM. No seizure recurrence for 1 year, seizure recurrence, withdrawal of AEM if no seizure, cyst resolved and no seizure recurrence, withdrawal of AEM, seizure recurrence, maintain AEM for 1 to 2 years after seizure. Surgical intervention, hydrocephalus due to an intraventricular cyst, placement of a ventricular shunt is recommended, followed by surgical extirpation of cyst and subsequent medical treatment. In cases of multiple cysts in subarachnoid space, that is the racemose form, surgical extirpation on an urgent basis is recommended. If the obstruction is due to arachnoiditis, placement of a ventricular shunt should be followed by administration of steroid and subsequent medical therapy. Surgical treatment in the particular case of medically refractory epilepsy due to a single lesion has been reported. Neuroendoscopy is a tool with great potential for use in the management of ventricular cysticercosis. Most patients with ocular or spinal lesions require surgical management. Surgical interventions also recommended for cysts attached to middle cerebral artery and compressing the optic chiasma. Follow-up imaging study is recommended after 2 to 3 months following treatment, especially in cases in which anti-cysticercal medications are used as a diagnostic tool. The use of imaging will guide the requirement of future trials of anti-cysticercal medication in cases of subarachnoid cysticercosis. Prognosis: in most cases, the prognosis is good. Seizures seems to improve after treatment with anti-cysticercal drugs. The racemose form is associated with poor prognosis and elevated mortality rate, that is more than 20%. 22% have recurrent seizures. Other includes headache, neurological deficits related to stroke and hydrocephalus. Patients with complications such as hydrocephalus, large cysts, multiple lesions with edema, chronic meningitis and vasculitis do not respond well to the treatment. Prevention: human tapeworm infection, inspection of pork for cysticerci, freezing of adequately cooking meat to destroy cysticerci, administering anti-parasitic agents to pigs. Infections in pig: confining animals and not allowing them to roam freely, improve sanitation conditions. Egg transmission to human: good personal hygiene and hand washing prior to food preparation, identifying human carriers of tapeworm, mass community program to treat tapeworm carriers. Possible vaccine: porcine vaccine currently in the work. Conclusion: neurocysticercosis is the major cause of epileptic seizures in developing countries. Varied clinical presentations preclude clinical diagnosis in most cases and demand imaging. Neurocysticercosis is potentially eradicable. Early diagnosis, individual case-based treatment and community measures for prevention remains the cornerstone of disease management. Thank you.